Hello, my name is Karina Wilkerson, and I will be discussing outpatient management of adults with sickle cell disease. Due to the complexity of the disease and time's constraint of this presentation, we will not be able to address all the many potential complications that can occur with an individual with sickle cell disease. I have no financial interest or relationships to disclose. The agenda for this presentation will be the introduction. We'll be identifying disease management therapies for sickle cell disease, our approach for acute and or chronic pain management, as well as management of transfusion iron overload. Sickle cell disease is an inherited blood disorder that is a multi-system disease associated with acute and chronic illnesses that can nearly affect every organ of the body. Disease management therapies can assist with preventing and managing pain episodes as well as complications. Vaso-occlusive pain, as you may know, is a major complication of sickle cell disease. Vaso-occlusive pain is a major cause of sickle cell-related morbidity, as well as it can negatively impact quality of life. Management of vaso-occlusive pain is complex and it requires an individualized approach. Psychosocial factors such as depression have shown to increase pain exacerbation, which can also lead to difficulties in managing pain. And it's also really important to understand that optimal management of sickle cell disease should be comprehensive. Lastly, but just as important, shared decision-making is a vital component of disease management. Patients with sickle cell disease experience extensive morbidity and early mortality. This picture highlights the many organs and potential complications that can impact an individual living with sickle cell disease. This graph analyzed the mortality reports among individuals with sickle cell disease in 1979, 1989, 1999, and 2006. The median age of death for adults was 39 in 2006 and 46 in 2015. Around 2017 to about 2020, 2021, there was additional therapeutic options for managing sickle cell disease. Now we are gaining more insight and can offer curative therapy options via stem cell transplant or gene therapy. In 2023, the FDA approved 2 gene therapy options for sickle cell disease. So, how do we manage sickle cell disease in an outpatient setting? First thing, we need to understand that sickle cell disease is a complex disease, and it can also affect many organs. So it is a multi-system disease. So addressing care in a systematically approach means that you are going to address this care comprehensively. And then you're going to take a deep breath, you're going to relax, and then you're going to address one complication at a time. You don't want to overwhelm yourself as the provider or the nurse or the patient. So in this case, we have a 28-year-old African-American female who arrives to your clinic to establish care. Her genotype is hemoglobin SS. Her past medical history consists of she's had multiple vaso-occlusive pain episodes, acute chest syndrome, iron overload, deep vein thrombosis, pulmonary embolisms, and splenectomy. As far as her disease management therapies, she's had chronic blood transfusions that has been discontinued. She also was prescribed hydroxyurea, but very inconsistent with therapy. She has not followed up with a sickle cell provider in over 2 years. She has not had any disease management therapy during those 2 years as well. She utilizes the ED for pain management, and pain is typically in her bilateral upper and lower extremities. So what are your next steps? So we are going to comprehensively manage this patient. So we are going to start our assessment with gaining more information on her pain episodes, psychosocial components, organ functions, disease prevention, as well as disease management therapies. These areas will help us have a better understanding of the patient, as well as serve as a guide for the provider. Currently, the disease management therapies for sickle cell disease are chronic blood transfusions, hydroxyurea, L-glutamine, and crizoluzumab. This table is a brief synopsis of each disease management option. It is broken down by age, your genotypes, mechanism of action, route of administration, your clinical effects of therapy, as well as your primary endpoint. And each of these disease management therapies have a different mechanism of action. For your blood transfusions, the mechanism of action is to increase your hemoglobin level and oxygen delivery, as well as reduce the hemoglobin S percent. Hydroxyurea, as many of you may know, have multiple mechanisms of actions, but the primary goal is to increase the hemoglobin F production. L-glutamine mechanism of action is uncertain, but is thought to reduce the NAD redox potential and possibly decrease in-cell adhesions. And then you have crizoluzumab, which is an anti-P-selective inhibitor that decreases adhesions of the white blood cells, the platelets, and RBCs to the endothelium. So hopefully this will result in decrease of vaso-occlusive pain episodes. So which therapy should we start for this patient? If you answered hydroxyurea, you are correct. This patient has not been on any disease management therapies for at least 2 years. She's had multiple vaso-occlusive pain episodes, acute chest syndrome. So it is recommended that you will start with hydroxyurea. Now, how do we address the pain? First, we need to decide, is the pain acute or chronic? Based on the epidemiology and the clinical data of sickle cell disease, it has become evident that sickle cell disease pain is complex and it can be divided in 2 categories, acute and or chronic. Patients that suffer from acute intermittent pain, it is most likely a result from vaso-occlusion. However, literature has shown that with increasing age, patients are developing more frequent pain and eventually evolving into what we call now chronic pain syndrome. The development of chronic pain suggests that other mechanisms independent of vaso-occlusion must be driving this transition from acute to chronic. Instead of a vascular basis for pain where vaso-occlusion results in tissue damage, ischemia, and pain in sickle cell disease may be due to the damage or changes in the peripheral or central nervous system. So, how do we address uncomplicated sickle cell pain episodes? Most sickle cell disease pain does not come to the medical attention. I like this picture of the glacier because sometimes providers and even family members may only see what's on the surface, not realizing what's happening underneath. They don't see how it's impacting the patient's school, work, home, life experiences. A lot of patients are frustrated because a nurse or provider tells them that they don't look like they're having a sickle cell pain episode, that they don't seem to be uncomfortable, which is not the case because a lot of our patients are taught to incorporate distraction mechanisms to kind of help them with their pain. I typically try to make sure we educate our staff and to let them know that we do educate our patients to do other things to kind of help them while they're going through a pain episode. I like, my mom would say a lot of times that appearances can be deceiving. You shouldn't base your opinion solely on someone's outer appearance. It may not reflect the truth. This figure shows the typical profile of painful events. On the y-axis, you see that there is a pain scale, and on the x-axis is the days of crisis. And as you can see, over time, the patient may experience different characteristics during different phases of their pain episode. So our approach is to recognize the different levels of one's pain episode and determine the best treatment plan with the patient's input so that we can better understand and manage their pain episodes. So we use a pain action plan. A pain action plan is a stepwise approach to treating pain at home using both narcotics and non-narcotic methods to treat pain. All of our sickle cell patients have an individualized pain action plan. We have a paper and an electronic copy saved into our Epic system. The patients and their family also have a copy of their pain action plan, and they are educated on how to manage their pain at home. We try to review each patient's pain action plan at least once a year. All adult patients have an ED pain action plan saved in their care coordination section in Epic. We have been very fortunate to collaborate with our ED colleagues to ensure that every single patient have this ED pain action plan, and ED staff know where to locate those ED pain action plans. We use our standard pain scales, the Wong-Baker FACES and the numeric pain scale. Our pain action plan is divided into steps. And so if a patient comes in or they're having pain at home and their pain is 0 to 2, then we tell them, let's try to use those non-pharmacological therapies. Let's try your hydration, your heating pads, your relaxation techniques. And then you may want to try your Tylenol or ibuprofen. If their pain does not improve and it worsens and it's from 4 to 6, then we want them to continue to do their non-pharmacological therapies. They can still keep their Tylenol and ibuprofen on board, but this is when they want to add your short-acting opiate. It's whether there's Loratabs, Percocets, oxycodone, morphine, whichever medication that the patient and the provider decide, that you want to have that patient start their short-acting medication. We also found that in our adult population and older adolescents, that if we add a scheduled extended release to their pain management, they have better control. So if this patient's pain is 8 to 10, they really cannot function, they're having a hard time, they can't go to work, then we want them to continue their immediate release and their extended release around the clock for a couple of doses. And if it doesn't get better, then they need to call us for next steps. So when they call our clinic, they speak to our nursing staff. Our nursing staff triage the patients, asks a few questions to kind of get a better understanding of what is going on with that patient. So during this time, it allows the patients to make sure that it allows the nurses to make sure that the patients are following their pain action plan. Sometimes we find out that those patients might not even have their medicines to follow their pain action plan. So this is a major opportunity for us to provide extra education to our patients. And if we find that they are appropriate to come in for pain management, some individuals call this, sites call this their day hospital, then they can come in the outpatient setting for pain management. If the patient's pain is complicated, where they have fever, shortness of breath, chest pain that's not typical, then we refer those patients to the ED. If our patients decide to go to the ED at our institution, then our nurses go ahead and initiate what we call an ED referral form, where we kind of give some highlights of what is going on with the patients so that the doctors and the nurses in the ER are aware. And then if there are any other acute medical issues other than pain, we refer those to the ED as well, unless they can be managed in clinic. Our day hospital and our inpatient pain management have a similar approach for pain management. So our approach is to provide optimal pain control. We do this by trying to make sure we maintain a therapeutic window. We use a short-acting and long-acting opioid in combination to maintain analgesia and to stay in a therapeutic window. So simply put, we want to maintain an opioid range that maximizes the analgesia, but that also minimizes side effects. So in this picture, you see that this is the limitations of the PRN pain medication. So typically when a patient comes in, some sites are not sure if they want to do implement a PCA or give them boluses. But we feel that if you give boluses or PRN pain medication, you'll cause this patient to not be what we call a therapeutic window. So their pain to get better, you give them a bolus, their pain, it subsides a little bit, then it spikes back up, then it goes down, it goes back up. So you keep going in this rhythm where you can cause mental clouding or other side effects. But this is also can be very frustrating for the patients and the nurses. So we like to use a continuous infusion to treat their pain. And so this will help patients receive medications around the clock that will also keep them within this therapeutic window. And again, even when they're are receiving different pain medications, but if they're doing it on a continuous basis, you will refrain from ideally going into those other potential side effects. Treating vaso-occlusive pain episodes in sickle cell disease, even if you're on a PCA, that doesn't mean that this patient won't have spikes in their pain. So that is where you can use your demand doses. So I tell our nurses and our staff that breakthrough pain is a sudden increase in pain. So when those patients are on that PCA and they have that sudden increase in pain, they're able to use their demand dose to kind of help treat their pain. And that treated in a very quickly manner instead of maybe having to wait for nurses to come in to be able to provide them with some relief. Breakthrough pain is a transitory flare of pain that is superimposed on an otherwise stable pain pattern. So normally it's moderate to severe in intensity. It has a rapid onset and then also short duration. Breakthrough pain was also identified in cancer patients. Literature has shown that it had occurred in about 2 out of 3 patients with terminal cancer. So treating breakthrough pain episodes in sickle cell disease is really important. So the PCA allows those patients to have adequate pain around the clock and also have an option to treat their breakthrough as well. So while staying within that therapeutic window. We also use ASH guidelines of managing acute and chronic pain and sickle cell disease, which is also a really great resource for your site. So how do we address complicated sickle cell pain episodes? As stated early in the presentation, chronic pain can be extremely complex. So you have your sociological component where you have your environmental stressors, your financial stressors, your disparities in care, stigma. The psychological component, patients are experiencing depression, anxiety, maybe sleep disorders, or even learned helplessness. And then biological, you have your erythrocyte sickling, your avascular necrosis, priapism, leg ulcers, and so on. And then as well as your neuropathic pain that we discussed previously, which is your peripheral and central sensitization. So pending your underlying causes will actually determine your next steps. Our approach to care is based on the chronic care model. We believe it is important for all of our adult patients to have a primary care provider. We try to make sure that each primary care provider is saved into the chart so we can have open lines of communication, as well as the primary care provider can assess for other chronic medical diseases that could be contributing to pain or the symptoms that they are having. And then, of course, you are going to focus on their disease-specific care, which is their sickle cell disease, and then care coordination. Living with a chronic disease can be very overwhelming to patients, and then it can also be very frustrating trying to navigate the healthcare system. So, a case manager to help those patients to get to their appointments, to identify any transportation issues, any financial stressors. Like it is very important to have a case manager on board. So let's get back to our case study. This patient was receiving chronic blood transfusions for pain management when she was managed by her sickle cell provider. She stopped following up with her sickle cell clinic and was utilizing the ED for her disease management. During this time, this patient received episodic blood transfusions. And per your assessment, she had not been taking any chelation therapy. So what about iron overload? Patients with sickle cell disease who are chronically transfused and have iron overload have a higher mortality rate than those individuals that do not have iron overload or who are transfused less. I like to tell my patients where there is blood, there is iron. So when a patient is receiving blood transfusions for disease management therapy or due to an acute illness over time, those transfusions can lead to transfusional iron overload. Iron overload can complicate various organs in the body, such as the heart, the pancreas, and the liver. Patients can develop cirrhosis of the liver, fibrosis, cardiac overload, and insulin resistance. In this study with Coates and Woods, they captured serial MRIs on different organs such as the abdomen, pancreas, heart, and they noted that iron loading and unloading occurs at different rates in different tissues. So these differences can impact the diagnosing and treating patients with iron overload. So how do we treat? So we know that in sickle cell disease, it is a condition with a strong inflammatory component. And ferritin, which is an acute phase reactant, may not accurately predict the body iron stores. So based on current available data, we developed this checklist as a guide. We have two checklists. We have a checklist for iron overload with their liver iron concentration less than 15 milligrams per grams. And then we have one that is their liver iron concentration that's greater than 15 milligrams per gram. So here on the left side, we have your diagnosis, your workup. So when we're assessing iron overload, we check a ferritin level on all our new patients, as well as we keep an eye on our patients that are being followed in our clinic. So if there is a transfusion history greater than 20 units of packed red blood cells, we make sure that we obtain that ferritin level as well. So our ferritins that are greater than 1,000 on 2 consecutive readings in a non-acute setting is really important. And so if they have greater than 1,000 in that non-acute setting, then that is indication for us to go ahead and order an MRI of the liver so we can obtain a liver iron concentration. Some sites may not have this capability, and so they might need to use a liver biopsy. During this, we are also evaluating the patient. So we're obtaining different labs. We want to also get a baseline audiology and ophthalmology as well, because if we do need to start chelation therapy, we want to make sure that this patient does not end up, if they have some issues in audiology and ophthalmology, it's not due to toxicity and it's prior to. And then once we identify the liver iron concentration, and if it's over 5, then that's when we want to initiate treatment. So we are either start with X-Jade or Jade New, depending on insurance preference. And then we will typically adjust those dosages as needed. We also like to keep up with their ferritin levels as well. And then if we need to reassess the MRI of the abdomen, in an insurance, you can do it 6 months if there are some changes, but usually 12 months. A lot of our insurances are okay with the 12 months versus the 6 months. So let's say that this patient is taking their X-Jade or J New, and we're not seeing a difference in their LIC or their ferritin, and if they're just not adherent, then we discuss sub-Q Desferal and see if that is a better option for the patient. Typically, sub-Q Desferal is ideally for 5 to 7 nights or days, but we know that that can be very challenging for our patients. And so we work really hard to figure out how many days a week do they think that they can actually do the treatment? Because we don't want to prescribe something that they're not going to do. And so once we do that, we will continue to keep up with those follow-up labs. We like to obtain those labs on a monthly basis, and then as well as annually continue to do those audiology and ophthalmology appointments. And during this time, our pediatric colleagues wanted to make sure that we added that growth charts for children are also very important when prescribing chelation therapy for children. And then you want to look at the precautions. So X-Jade and Jade New are contraindicated in renal and hepatic failure patients, as well as thrombocytopenia. Hopefully your patients are adherent, you guys have a good relationship, and they're taking their medicine, there's no issues with insurance, and you start to see the ferritin decline and the LIC decline. Then you can start doing dose adjustments. But if not, then we have to go on to our next slide. So for iron overload, with their liver iron concentration greater than 15 milligrams per gram, or a cardiac iron overload where their T2 star is less than 20 milliseconds, then this is the workflow that we use to kind of manage these individuals. So on the diagnosis workup section, we define severe iron overload is any liver iron concentration that's greater than 15 mg per gram. During this time, we also has found that a liver iron concentration that's greater than 15 mg per kg that's more than 2 years, or there is some evidence of cardiac dysfunction, then we would like to go ahead and order the cardiac MRI as well. And if you have some adolescents or older adolescents that have severe iron overload, then we just want to make sure that you order the cardiac MRI for those that are 15 years of age or older. And the baseline labs are pretty much the same. There's not a lot of changes with the baseline labs, but we felt that when somebody has made it to chronic severe iron overload, that we implement our social worker into the mix. We try to implement our social worker whenever we have management changes, but especially when a patient has liver iron concentration that's greater than 15, because we want to know, are there any other psychosocial components that could be contributing to this patient not being able to take their medicines on time or not be able to receive their medicines, or is there transportation, insurance? Like, we want to find out, are there any other barriers that can be contributing to this patient inability to take this medication or adhere to it? So with our dual chelation therapy, we continue our exjade and jade new, and then we have that sub-Q desferal going. But sometimes sub-Q desferal is not covered by insurances. And so I have a patient now that is on jade new, but it also coming in for inpatient management because they are rather pay for the inpatient management of desferal than sub-Q desferal. So if you have a patient that has some insurance barriers for sub-Q desferal, or there is an adherence problem, or they're just not seeing it being effective, like they're saying that they're doing the sub-Q, they're doing the JNU, and nothing is changing, then that's when you can bring them in to do your inpatient pain management strategies. And then here's the algorithm that we use, is posted there. Typically, majority of my patients come in for 48 hours. That's about all that they would do for me once a month. And then you're going to continue your management adjuncts. You're going to monitor your labs as well, keep a close eye on, now that you're going to do your liver MRI as well as your cardiac MRI, because you want to see those levels improve. And again, your precautions, XJ new is indicated in renal insufficiency and hepatic failure and thrombocytopenia, and platelets count less than 100,000. Recently, I've been working with pharmacists and looking at the literature. And so those patients that may have kidney, AKI, chronic kidney injury, maybe stage 1 and 2, even 3, then Theraprox may be a better option for those individuals. And then if we continue to see that their LIC is not improving, that we have tried transitioning those patients. Most of those patients maybe have transitioned from chronic blood transfusions to maybe hydroxyurea. And we keep trying to figure out what else can we do for these individuals, because typically if their LIC is greater than 15, and they also have cardiac iron overload, this may be our severe sickle cell patients. These may be our patients that are having chronic complications, organ damage, dysfunctions. And so this is when we may discuss transplant options with our colleagues to see, do they have meet the criteria for transplant. Shared decision-making with the patient and a multidisciplinary approach is imperative in the overall management of sickle cell disease. One case, and we was able to go through all these different potential complications that can occur. So it's really important for the patient to be involved in that plan of care for them. Individuals living with sickle cell disease requires a coordinated multidisciplinary approach. We try to make sure that every single patient has a medical home, and the specialists that are within that medical home, that they know who they are and how to contact them. And then, of course, going back to our case manager, care coordination is extremely vital for this patient population, because you want to make sure that we are improving the overall health outcomes. So I want to thank you for your time, and I would like to acknowledge my entire team for their support and their contributions to this presentation. Thanks.